All right, well, today for our expert interview, we have Dr. Jeff Hunger, who is an assistant professor at the Department of Psychology, Miami University of Ohio. Jeff, thank you for taking the time to talk to me.
Yeah, thank you so much for having me.
So I really like to just start all of these by asking people, what are the research questions that really guide your work?
Yeah, so at the broadest level, my research is interested in what are the mental and physical health consequences of being a target of stigma. A lot of the work, like the paper that you read for class today, centers around weight stigma in particular, but I do a little bit of work in sexual minority stigma, some emerging work in race-based stigma, but yeah, really broadly, that's the interests of our lab.
Okay, and I tell this to everyone, but based on what you just said, it's self-evident to me why that's important, but I also like to give the expert the opportunity to expand a little bit more. So why do you think this is such an important area of research?
Yeah, I think well, I mean, if you would have asked me a few weeks ago, I would have said it was an under-recognized contributor to health disparities. But now that that's sort of been at the forefront of a broader conversation that we're seeing in media and more of a sort of public discourse, I think it sort of resonates with.
Sorry, so can you clarify it just in case maybe people aren't catching up on the media that you're referencing?
Oh yeah, so as at least in the United States, we have sort of had a reckoning with our history of racism and race-based health disparities sort of all coming to head over the past few weeks, where as these conversations about how, in particular, Black people are treated by institutions like our police, it's also brought to mind these huge disparities that exist between Black individuals and white individuals when it comes to their physical health and their mental health here.
Okay, so stigma as something worth studying in its own right, but also as a way that it contributes to intergroup disparities related to health.
100%, and huge disparities both in mental and physical health, and that's one of the things that I think is maybe missing a little bit from the conversation right now, because it's also sort of couched in we're seeing huge racial disparities in rates of coronavirus infection and coronavirus death, and so I think that has sort of sharpened our focus on the physical health aspect. But experiencing stigma and discrimination is also a huge predictor of a whole host of mental health outcomes as well.
Okay. Yeah, I mean, that's obviously a very important research topic, so I'm glad you can tell us a little bit more about your work right now. So in class, we talked a little bit about weight stigma. And as the expert, are there aspects of weight stigma that you think are fundamentally different in terms of other popular stigmas in research, like race and gender?
Yeah, I think when we think about other really, common stigmas that are studied in social psychology in particular, it's the big three are race, gender, and sexual orientation. And one of the biggest sort of characteristics that separates those from, say, weight stigma is the idea that weight is still seen as, by and large, under a person's individual control. And so if they want to, escape this stigma and this discrimination that they are facing, all they need to do is lose weight. We would never tell a person that they need to change their race as a solution for escaping race-based discrimination, for example.
I see. So it's interesting that you referenced that related to sexual orientation, because maybe if we were having this conversation 40 or 50 years ago, not over Zoom, over some sort of telephone or phonograph, maybe people would have said that sexual orientation was something else that was under a person's control. So I don't think I think that perception has certainly gone down in the last 40 or 50 years. Do you think something similar will happen to weight over the next 40 or 50 years?
Yeah, I agree with you that, that has changed remarkably over the past 45 years or so. It was in 1973, being gay was still considered a mental disorder according to the Diagnostic and Statistical Manual. So we've seen a lot of improvements there. We've also seen a lot of improvements in terms of mental health stigma. So people used to think that alcoholism and depression were equally as under, individual control, and you could just pull yourself up by your bootstraps and get out of those conditions as well. But as the science related to weight and weight loss and health has evolved over the past 20, 25 years, we've actually seen the anti-fat bias increase over that same period. So as much as I would like to be optimistic, there's the pessimist in me that has kind of followed this field for the past 12 or 15 years that thinks that it's going to take, I think, stronger interventions than just kind of letting the information naturally evolve over time.
Oh, okay. Well, I'm getting off course, but you're saying so many interesting things. Okay, so do you have thoughts on what those really strong interventions might be to change people's thoughts about weight?
I think if there's anybody that's going to have a stronger opinion on interventions for reducing biases, maybe you. You probably have a little more
Okay, yeah, we can
experience with
talk.
that than I
That's something
do.
that the students watching this will have to touch upon. But it is interesting, this point that you're making, that, you know, there's a disconnect here between the science and public opinion or popular attitudes here. And so we can't just necessarily rely on, as we know more scientifically about these topics, surely the public attitudes will follow as well. There can be a disconnect there, and that's what we're seeing with weight.
Yeah, and it's
So let's
really
get,
hard. Oh,
go ahead.
I was going to say it's really hard though. Also, when we think of sort of large organizations or structures like the medical establishment, that we get a lot of our information from, that are very resistant to taking a more holistic approach to weight and health, and taking a more fair and balanced sort of view on the existing literature on like what it actually says. It's really hard to have conversations with doctors, for example, and tell them, you know, actually maybe weight loss isn't the ideal way to improve the health of your patients, because there are all these other things like improving health behaviors, reducing stress, and, you know, changing other factors that can change independent of weight that will improve their health and their longevity. But it's very hard to really pull them out of that weight-centric sort of model. They are a tad dogmatic about it.
Yeah, because weight could be another topic where people feel very confident in their wrong beliefs about how it works. It's not as if they're willing to admit their own lack of knowledge. This is a problem that a lot of people have solved mentally, even if they've solved it the incorrect way.
They're done, yeah.
Yeah. So let's talk a little bit about the study that you ran in particular. Always nice to see a good Confederate study in a social psychology class. So from a methodological standpoint, could you tell us a little bit more about why you thought it was important to run a Confederate study?
Yeah, so we, you know, in our lab in graduate school and in the work that I do now, we want to make sure that the manipulations that we use and the things that we expose our participants to have at least some analog to the real world. We obviously, for ethical reasons, it has to be like what I have called stigma light, because we're not going to expose participants to the real things that they actually experience in their day-to-day lives, you know, living in a fat-phobic society like the US. But something like using the Confederate paradigm like this, it has a social component. It feels a little bit more real life, but you know, as your students have seen from reading the paper, the Confederates' bias was just read about. Nothing was even expressed in the interaction. They barely even interacted. All they did was play like a word find game. And that was enough to elicit threat. So you can imagine that what we're doing in the laboratory setting is high impact enough because there's another person there, but it's still probably a conservative estimate of like what they're really feeling when they're walking down the street and somebody yells out a fat-phobic comment, or someone comments on the foods that are in their grocery cart while they're at the grocery store, which are like actually very commonly reported experiences for higher body weight individuals.
Actually, jumping off of that point, you know, there was a very strong paper, but one of the weaknesses that you mentioned in your general discussion is the lack of a control condition, because you only gave people who were high on anticipated prejudice versus low on anticipated prejudice. So, you know, if you were to run the study again or go back in time and run a control condition, and what do you think people who are the target of weight stigma project onto the average, project onto people that they don't know anything about, you know? That question makes sense.
Yeah, it does. And so it's interesting because the control condition for this study wasn't the peer control condition where they, you know, they just did nothing.
Yeah.
They also kind of reported on their anti-fat attitudes, and we tried our best to yoke them to what was like the general anti-fat attitude level of the Santa Barbara community. Mm-hmm. And so in that respect, it's kind of like a control of what they may have experienced in their day-to-day life. But you can imagine a few different controls, of one being something where it's not threat versus control, but threat versus safety. You know, so going really far with that person being super egalitarian on the dimension of weight. Because if we do something like that, it takes out potential individual differences in, like what you're saying, what people walk into and would project onto a stranger. We know that that's going to be shaped by things like how rejection sensitive are they on the basis of weight? How high on, you know, stigma consciousness are they? How frequently are they really thinking about these things? And so if we wanted to, it's something really interesting to study just in and of itself, like what are people projecting onto strangers when it comes to the potential for bias. But if we wanted to like pull that out completely, I would say maybe using a stronger control condition that was really about like identity safety versus this sort of identity threat.
Okay. Yeah, I mean, to critique my own question, you nicely pointed out that that was kind of a one-size-fits-all question, but of course it depends on many individual differences like stigma consciousness as well. So, well put. You also used cardio or physiological data for this study, and I know you come from a background in that. In this course, and I think in intergroup relations research more broadly, we don't use a lot of cardio data, physiological data. What are the values of using those types of measures?
For someone that's really interested in the health consequences of these types of interactions, one is it's like a really clearer relationship between, say exposure to threat and cardiovascular reactivity, which we know that chronic cardiovascular reactivity, especially when that is prolonged, has consequences long-term for cardiovascular disease, atherosclerosis, heart disease, all of those things. So it's nice to see that we can, it's clearer, or like it forms a clearer link between, the acute things that we want to study in the lab and then the long-term health outcomes that we want to talk about when we say, okay, we're capturing one instance of this at one time point in their life. If this happens daily for 20, 30, 40 years, what's sort of that accumulated risk that comes along with this? So that, for someone who's really interested in the health consequences, is why I do it. I know a lot of people will also say that it's a more indirect way of getting at if a person is threatened. In our data, people are readily, able to report when they are stressed, when they feel threatened, when they don't want to interact with this person. But in other intergroup relations work, I know people have used it to sort of be almost like a non-conscious or implicit measure of threat, particularly for the dominant group. So I believe it's Jen Richardson's group, has some work on, we can use cardiovascular indices, not necessarily as just a thing that's going to project or predict long-term health outcomes, but something that, the participant isn't willing to or able to report. They don't want to say that they're threatened by interacting with a person of color, because in a society that values egalitarian behavior, that sounds pretty bad. So if they're not willing to report it, maybe we can see it, at the physiological level.
Right, yeah, so that's certainly the second interpretation that you gave is certainly how I'm more used to seeing it, that it's another implicit measure. You can get at people's responses that they're either unwilling or unable to report. But I really like the first part that you brought in as well, as a way of simulating some of the corrosive effects of some of these physiological experiences. If this anticipated rejection can make your heart race like this, maybe that's not a scientific term, and we know that this can over time worsen health outcomes, then what we're capturing in the lab, we can make a tighter connection between what we're capturing in the lab physiologically and how these things can build and deteriorate on our health over time. So that's a great response.
And it's really
thought of it before, showing my ignorance a little bit, but that's why I'm doing these as well.
No, go ahead.
You're up.
No, it's all you. I want to hear the next question.
So another thing I noticed about the study was that you limited it to female participants, which in your general discussion, you make good points about. But it's worth asking, so do you think that, within your own study specifically, and within the experience of weight stigma more broadly, are there gender differences between males and females?
Yeah, so it's a really great question, and I think something that the weight stigma field has done a pretty terrible job of addressing until about the past maybe 2 or 3 years. For the first 10 or 12 years of this research happening, the reason cited for using only women was that the study before you used only women. And so that's not a great justification. There should be more theoretical and sort of more meat to selecting just a subset. But in our data, if anything, it's that mean levels differ. So for example, women tend to experience more discrimination on the basis of their weight. They also tend to anticipate this treatment more than men do. So there's this mean difference that we've seen time and time again. However, when we bring sort of these concerns online, the relationship is pretty much the same. So it's like from like a statsy nerdy thing, it's like a intercept slope difference. But
Okay,
for
break that down a little bit.
but yeah, but for the students in this class, although there might be mean differences in how frequently, one gender or the other experiences these things, once they experience them, the consequences are the same. So if we put men in this situation, we would expect their heart to race just as much if they were interacting with a potentially anti-fat peer. They would feel just as stressed, just as unlikely to want to interact with this person in the future, things like that. We don't really have, that's my working hypothesis. Obviously, I need to be running these studies with both men and women to confirm that. But for the time being, there's not going to be a lot of in-person research happening in my lab.
That's true, but okay, so if I can maybe extrapolate from that a little bit, if you feel pretty good that if you were to run this study with male participants, because once they experience a threat related to weight, they tend to experience that at the same intensity, and that's what your manipulation was doing as female participants, that you feel like you would probably find similar things.
I think so. I think where it might look different is if the manipulation was a little bit more domain specific. Mm-hmm. So for example, we do have some previous research that shows that, and this is consistent with what we know in general, that men feel less threatened in the dating context related to being stigmatized for their weight in the dating context, because we know that women, far more than men, are penalized in terms of they are stigmatized at lower weights, particularly in romantic relationships or in romantic contexts. Mm-hmm. And so for some of the previous work where it's romantic relationships specifically, it seems to be the case that men are less threatened than women are. But I think that we could equally find domains in which men might be more sensitive to threat than women.
Do you have a domain off the top of your head?
Probably should have thought about that a little bit before I said that sentence, but
no,
you can imagine maybe they're similar, or it's particularly salient in sort of employment contexts for men.
Okay, yeah. That would be, I don't know anything, but I can imagine that would be one where we'd see more equality between the experience of anticipated rejection or stigma between the genders rather than the romantic context. Yeah. Jumping off that point, imagine that you were able to resume your in-person data collection. Do you have any current lines of research that you're really excited about, that you feel like are making progress on these types of questions?
So we haven't really launched into some of these types of questions that are really, these are rooted in this idea of needing to push the weight stigma domain into a framework that acknowledges how individuals contend with like multiple identities, and particularly like multiple stigmatized identities. Like, this is something that I would really like to do in the future. Was planning on starting things up hopefully either last year or next year, where we start to look at how, encountering weight stigma may look different for men and women, might actually sort of result in different outcomes or different consequences at sort of different axes of subordination. So thinking like, does weight stigma manifest similarly for Black women as it does for white women? And are the situations and the consequences that elicit this type of threat going to be equivalent across those groups? Things like that really sort of adopt an intersectionality approach. I don't know if that has come up yet or will come up in the class.
We'll get there.
Yeah, but we need to be thinking about how these different forms of identities, whether they be gender or race or sexual orientation, interact and sort of shape one another's manifestation. Because by and large, the weight stigma literature is white women, and as our participants, that's an issue because that's only capturing a sliver of our ever-growing diverse population. And so one of the things that I was excited about was sort of trying to push into and think through how we can take an intersectional lens to understanding the consequences of weight stigma.
I think that's spot on. Even in the structure of the class that they've been seeing the past few days, we talk about these stigmas as their own little separate silos. Here's how stigma works about sexual orientation. Here's how stigma works about weight. But maybe it's just because that's the way we've been trained to think about it. Maybe it's because the data right there are lacking, but I imagine that over the next years to come, we're going to see a blending of those into a more intersectional approach to see how these stigmas kind of interact with one another.
And I think part of what's driving it is it becomes incredibly challenging to do these like high impact studies like the Confederate paradigm, once it starts to get a little more nuanced. So like for if a careful read of that paper, you'll see that we gender and race, we race matched the Confederates so that we could guarantee that this was just something about weight and not about their race or their gender. So if we add another dimension of social identity to the participant, that makes constructing the experiment that much more complicated to pinpoint that this was something about that intersection. Does that make sense?
Yeah, that makes a lot of sense. We'll tie this into other class discussions about what kind of research is incentivized, but what you're pointing out is a real tension between what's rewarded and what I think a lot of people are agreeing more and more about what we need to study. The study that you're proposing would be really, really impactful work on how these stigmas intersect with one another. It would also be, even if there weren't a pandemic going on, such an investment to run that people would need more of an assurance that they're going to get the recognition for that work before they even run the study. So yeah, we're working on that on a couple of different levels, but we'll talk about that more in class. I guess related to what you just said, but maybe you can give me another response. I like to end these things with a question of what other issues do you really hope that this field makes progress on in the next 5 or 10 years? What are the things you're really hoping that we're going to be able to tackle in the next 10 years?
Yeah, so I think I touched on that a little bit. I think really adopting this or acknowledging the fact that folks have multiple identities and that identities don't operate in a vacuum or in their own silo is going to be incredibly important. I think more and more having conversations with allied fields, like talking to and collaborating with public health scholars or population health scholars to bring my expertise and their methodology together so that we can really get this from the lab to the population and get a full understanding of how these relationships play out at all of these different levels, and how, you know, broader things like structural forms of these biases or institutionalized forms of these biases play out. I also think that even within psychology, we could do a better job of connecting to, say, like clinical psychology, for example, which is something that I've been pushing us into in my lab a lot, because these experiences, particularly, you know, with the weight stigma that we've been doing lately, has huge implications for things like disordered eating and unhealthy weight control behaviors. And that has only sort of been scratched the surface of, and there's been no experimental work that has looked at that yet.
Wow, okay, that's a great response.
So like really bridging what we know as social psychologists, you know, we're a hub. I think of us as like a hub discipline. We are trained to think about things that impact a lot of people. We may not have the exact methodology to, you know, say run a gigantic 5,000 person 16-wave epidemiological study, but so that's why we partner with them, or we partner with clinical, or we just get ourselves out of our own little bubble.
Well, I think that's very apt for the time that we're in. We're all living in a bit of a bubble, but as we're expanding out and trying to use these connections across fields to really make higher and higher impact and bridge these literatures, I think in 10 years, maybe you'll come back and you'll tell me that we achieved it, or it's something that we still need to keep working on. But Jeff, I really thank you for your time, and thank you for telling us a little bit more about your work.
Yeah, I really appreciate it. I hope you guys have a good day.
All right, see ya.
Later.